morning all. Very nice to be here today. I'm sorry, but my Norwegian is very bad, so I'm sticking to English. My name is Lionne Venderbos, and I'm working at the Department of Urology of the Erasmus University Medical Center. And I'm working in the group of Professor Monique Robel, who's been working on the ERSPC study, the European Randomized Study of Screening for Prostate Cancer, since the very beginning in the 1990s. And we've been working together for 16 years now, so that's very nice to be working with such an expert on screening for such a long time. I've also had the courtesy to work for a few years with Professor Schröder, Professor Fritz Schröder, who some of you, I guess, might know from the past. And today I would like to talk to you a bit about the past of screening, the present, but also the future. And I'm doing that in the context of the Praise You project, which has started on the 1st of April of this year. So on the agenda today is some of the history of cancer screening, some of the ongoing screening trials, the lessons we have learned so far, and the Praise You project, because we want to go from screening trials to pilot studies, population-based pilot studies. So let's start with the history of prostate cancer screening. And in the 70s and 80s, we started off with the pre-PSA screening era. And at that period of time, there was still 1 out of 2 to 3 prostate cancer patients who died of their disease. Men showed up with symptoms at their urologist, and that was already a worse status of their prostate cancer. If we look at the incidence and mortality data today, then prostate cancer is still a very common, and it's increasing. From the global CAN data of 2022, we see that prostate cancer is the second most frequent cancer and the 5th leading cause of cancer death among men worldwide. And it is expected that in 2025, the incidence of prostate cancer will be 1.8 million, and 500,000 men will die of their disease. So what I would like to do now, on the left side, I will show you a timeline on which I will take you along with scientific evidence that has been gathered over the years. And then on the right-hand side, we will see the guideline implementations that have been made throughout the years too. So we start in the 1980s, when the pre-PSA era was still there. The earliest reports on prostate-specific antigen were already out in the 1960s by Ruben Vloks, but it still took around 20 plus years of research before the Food and Drug Administration in the United States approved the first commercial immunoassay for PSA testing. And when the PSA test was introduced, we saw that the incidence of prostate cancer rapidly increased. But it also gave an opportunity, because till then we had the DRE and we had prostate biopsies to diagnose prostate cancer with, but now we can trust or build on a 3-legged stool and include PSA in the diagnostic algorithm for prostate cancer. And that was also when the first thoughts were about prostate cancer, starting prostate cancer screening. So Professor Schröder, together with other colleagues, they started thinking about setting up a prostate cancer screening trial to see whether screening could reduce prostate cancer-specific mortality. And actually, in the beginning of the 1990s, in Europe, the European Randomized Study of Screening for Prostate Cancer started. And at the same time, in the United States, the PLCO study started. So the prostate, lung, colorectal, and ovarian cancer screening trial started. And both had the main endpoint of prostate cancer-specific mortality. Then we had to wait for a very long time, because a screening study takes a long time. And in 2009, the results of both studies were published side by side in the New England Journal of Medicine. And it actually caused a big controversy because the ERSBC study showed a relative risk reduction of 20% in prostate cancer-specific mortality using screening and a 30% reduction of metastatic disease at diagnosis using PSA-based testing. Well, at that point, the PLCO study showed no effect at all. And then we came into a time where there was a lot of debate about both studies, about the quality of the studies, about, well, literally all aspects of the studies. But luckily, we could at some point move beyond that discussion, because in 2016, the discrepant effect on mortality that was found in the ERSBC and the PLCO trials led to a re-evaluation of the control arm of the PLCO trial. Because in the control arm of the PLCO trial, it turned out that 90% of the men had at least one PSA test already, which is causing contamination. And this seriously reduces the power of your study to show an effect of the intervention and on prostate-specific mortality reduction. So after accounting for the differences in the implementation, the ERSBC study showed a 25 to 30% reduced risk of prostate cancer death in their core age group, so in men aged 55 to 69 years, and the PLCO showed a 27 till 32% reduced risk of prostate cancer death compared with no screening. And of course, in that period between the 1980s and 2016, policy and medical guideline recommendations had to be made. So in 1987, the FDA approved the first commercial immunoassay for PSA testing, and in 2002, the United States Preventive Services Task Force published that the current evidence was insufficient to recommend for or against routine screening for prostate cancer. Well, that was logical because the screening studies were still running and no results on the primary endpoint had been published yet. After 2009, after both the ERSBC and the PLCO study published for the first time on their primary endpoint, the European Association of Urology in 2010 made a recommendation for individualized risk-adapted strategy to well-informed men and to men with a life expectancy of 10 to 15 years. In 2012, the United States Preventive Services Task Force actually recommended against prostate cancer screening using PSA testing, as we learned from the scientific literature later on that had an effect as well. But what we already knew when both studies published their results was that the screening algorithm that they had been using was not a future-proof algorithm, because from both studies we learned that there was a lot of overdiagnosis and subsequent overtreatment. So in moving forward in this debate, we had to look for how to adjust the screening algorithm, how to make it future-proof. So the EAU recommended at that time to perform a multiparametric MRI before prostate biopsy. And in Europe, at the same time, Europe's Beating Cancer Plan was introduced because they had been noticing also the discussions that had been going on about the big screening trials, and their last action plan actually against cancer was developed in the early 1990s. So they realized that a lot of progress had been made since then and that they had to renew their commitment to cancer prevention, treatment and care. The notion was really there that future screening algorithms had to be risk-based. So in 2021, Professor Hein van Poppel and colleagues published an algorithm on how screening could be done risk-based. The debate between the ERSBC and the PLCO trials was also reflected upon at an EU policy level, because the new evidence from the PLCO trial that was published in 2016 sparked the need to revisit the policy recommendations. So the European Council requested the scientific advice for policy by European academies, so the SAPIA, to conduct a comprehensive review of the current scientific evidence regarding prostate cancer screening. And in 2022, SAPIA's review served as the foundation for the updated recommendation by the Council of the EU to recommend the member states to evaluate the feasibility and effectiveness of organized prostate cancer screening. And the European Commission then also opened a call to further investigate prostate cancer screening. And under the guidance of the European Association of Urology, the PRAISE-U project was submitted, and it was accepted. And on the 1st of April this year, the project has started, and I will tell you more about the PRAISE-U project in a few slides. So the policy and medical guideline recommendations. So we left off with the recommendation in 2012 of the United States Preventive Services Task Force, and in 2018, after evidence became available on how that 2012 negative recommendation impacted prostate cancer incidence as well, the United States Preventive Services Task Force in 2018 recommends now individualized testing to well-informed men in the age category of 55 to 69 years, and having shared decision-making together with them. In 2021, the EAU recommendation to a risk-adapted early detection strategy for prostate cancer in well-informed men was included in the guidelines. It was just also shown on the slide of our previous speaker. And in 2022, the European Commission recommends expanding screening to other cancer types, including prostate cancer. And the SAPIA evidence review said that there is now strong scientific evidence for the benefit of organized prostate cancer screening using blood tests, particularly combined with follow-up MRI scans. What we already learned from the ERSPC and the PLCO trial is that, like I just said, that the screening algorithm that we used there was not the way forward. It was not future-proof. It caused too much overdiagnosis and subsequent overtreatment. So in the meantime, new screening studies have been initiated, and here is an overview of the currently ongoing screening trials. So we have the PRO-based trial in Germany, which is led by Professor Peter Albers, and it's a risk-adapted PSA screening trial based on baseline PSA at the age of 45 or 50. And currently they have recruited all men into their studies. That was in December 2019, they reached that milestone. And now slowly reports are being published in the scientific literature about the results of the first screening round. In Finland, we have the PRO-screen study, which is under the guidance of Professor Anssi Auvinen. And there they are applying a risk-adapted PSA screening, the use of a multi-callicrine panel, the 4K score, and MRI. In Sweden, the Göteborg 2 trial is running under the guidance of Professor Jonas Hugosson. There they are using PSA versus PSA plus MRI. We have the Stockholm 3 trial, also based in Sweden, under the guidance of Professor Tobias Nordström, with MRI targeted versus standard biopsy and Stockholm 3 risk stratification. And in the UK, we have the Reimagine trial under the guidance of Professor Caroline Moore. And that's actually a feasibility study in which they are looking whether MRI can be used as a population-based screening method. So in the coming years, we will learn a lot from these studies and learn whether certain risk stratification steps can be included in our algorithms and how that affects our results. But what do all these ongoing trials have in common? Well, they are actually building on the trials, the ongoing trials actually build on the 30+ years of experience that we have gathered with the ERSPC and the PLCO trial, and they are using new technologies now for prostate cancer detection. So they use risk calculators, they use MRI, they use urine biomarkers. And we have learned a few lessons in the last couple of decades. And that is the importance of risk-adapted screening. That's, we believe, the way forward. Some important findings to consider is that the life expectancy of a man at the start should be 10 to 15 years. We have seen that a yearly PSA is actually too much to do. We have seen that risk stratification by using risk calculators, for instance, shows to result in a reduction in the number of MRIs that is being performed and the number of biopsies that is being performed and leads to less overdiagnosis. We have seen that the introduction of MRI shows to result in less biopsy procedures, in a better detection of low-risk prostate cancer, and a better detection of high-risk prostate cancer. And we've seen that offering men active surveillance, of course, to whom are eligible, shows to result in a decrease in the active treatment and in the overtreatment. But with respect to active surveillance, we want, of course, not to detect those men at all at first, if that's what we're striving for. So, throughout the years, we went through several policy changes. We went to guideline recommendations pro and against screening. We went through the golden era of PSA testing. We had the debate around PSA testing. And we have new evidence coming up from big trials and now new policy recommendations. We therefore can conclude at present that the PSA test in itself is a powerful stratification tool for establishing a baseline PSA level among healthy men. That a risk-adapted approach is needed to avoid overdiagnosis and overtreatment. That big trials are of course still ongoing, but new ways of smart detection need to be tested as pilot studies in different countries to implement the learnings of the last decades of research. And those learnings need to be translated into the context of a specific countries, so we need to go from a trial to a population-based program. And that is actually what we're doing in the PRAISE-U project. So the PRAISE-U project was accepted by the European Commission and is under the leadership of the EAU and has gathered several experts in the field of prostate cancer screening to work together. It started on April 1st this year and it will take 36 months, and we have some sister projects as well. SOLAS, which is on lung cancer, and TOCAS, which is on gastric cancer. We are with a consortium of 25 institutions from 12 member states, and we include academic partners. We include the members of the ERSPC trial, but we also include experts on the field of economic evaluation. We included WONCA, for instance, the General Practitioners Organization in Europe, the patient organization Europa WOMO, but also IARC, the International Agency for Research on Cancer. And the missions of PRAISE-U are to get an insight and assess the needs in EU member states, to design a diagnostic strategy and algorithm for EU prostate cancer screening that is both cost-effective and is able to raise awareness of prostate cancer and its implications. to have EU member states tailored recommendations on screening strategies that will be based on available knowledge on specific risk groups, a multi-step risk-based early detection strategy including individualized interval for PSA testing combined with risk calculators and imaging modalities such as multiparametric MRI. And we believe that this will allow for an approach avoiding unnecessary repeated testing, overdiagnosis, and consequently will reduce overtreatment as well as the number of men diagnosed with metastatic disease and mortality. And PRAISE-U is divided into several work packages. And as said, we have a very strict timeline. We have 3 years in the project. And in the first year, we are making a needs assessment and a state of play report, and we're developing the pilot site specific study protocol so that in year 2, the study of the pilot sites can start. They have a year for that. And after that, in the 3rd year, we will have detailed evaluation, of course, of the pilot sites. And here you can see a map of the centers where the pilot sites will be running. We have 2 in Spain, 1 in Lithuania, 1 in Poland, and 1 in Ireland. And some of the members of the OPT cancer screening program from Sweden are also included in our consortium, so we can learn on the experiences that they have already gained during the last years in setting up their program. So to conclude, we are building our current knowledge on a long road of screening history in prostate cancer, and we are still learning from important trials across Europe, and we will keep learning from these trials the coming years. We learned important lessons and must act on those by using risk-based screening strategies. And PRAISE-U offers a new opportunity to apply our learnings and to continue to learn more outside of a trial setting, but in a population-based study setting. Thank you very much.